Assalamu alaikum. Our lecture in advanced oral histology is the regulators of bone remodeling. Bone remodeling is a process by which overall size and shape of the bone is established and extend from embryonic bone development to the pre-adult period of human. This is done by osteoclast and osteoblast cells. Bone remodeling involves the removal of mineralized bone by osteoclasts followed by formation of bone by osteoblasts that subsequently become bone deposition in more rapid than bone resorption. It is 30% to 10% per year in childhood. Turnover doesn't stop at adulthood but continue in a slow rate. Osteoblast cells is a mononucleated cells and secretion of the macromolecular organic constituent of bone tissue control bone mineralization. It derived from osteoprogenitor cells of the mesenchymal origin. This is the pre-osteoblast in electron microscope, and this is osteoblast. Stem cells give rise to stromal mesenchymal cells, which give rise osteoprogenitor that give a pre-osteoblast, then mature osteoblasts which form bone, and then become in lacunae and form osteocyte inside the bone matrix. Osteoclast cells is multinucleated giant cells, like in this slide, identified easily under the light microscope and often are seen in clusters involved in bone resorption, derived from hematopoietic progenitor in the bone marrow, which also give rise to monocytes in peripheral blood. Function: bone resorption, highly specialized cytoskeleton and have ruffled border like in this picture. Osteoclast from macrophage, osteoclast precursor, and then multinucleated osteoclast, and this osteoclast in house-shaped lacunae on the periphery of the bone matrix. Activated osteoclast when form bone resorption. Sequence of bone remodeling. This includes 4 stages. First, activation. The cells of osteoblast lineage interact with hematopoietic cells to initiate osteoclast formation. This stage of bone remodeling involves detection of initiating remodeling signal, can take several forms like direct mechanical strain on bone or hormonal action. Second stage is resorption. In this stage, osteoblasts respond to signal generated by osteocyte and recruit osteoclast precursors to the remodeling site. The osteoclast tunnel into surface of bone, which lasts for 3 weeks. Third stage of bone remodeling is reversal, comprising the differentiation of osteoblast precursor and discontinuation of bone resorption with osteoclast apoptosis following osteoclast-mediated resorption. The house-shaped lacunae remain covered with undigested demineralized collagen matrix. A mononucleated cells of undetermined ligand remove these collagen remnant. Fourth stage of bone remodeling is the formation. Activated osteoblast lay down in new bone material until the resolved bone is entirely replaced by new bone. This picture shows the 4 stages of bone remodeling: activation, resorption, reversal, and formation. The OPG RANKL system. Cytokine system is essential for the osteoclast biology. Various studies suggest that human metabolic bone disease are related to the alteration of this belong to the tumor necrosis factor receptor superfamily. OPG homodimer is a member of the tumor necrosis factor receptor family, but it is secreted and acts like cytokines, bind to the RANKL, stromal cells and osteoblastic lineage cells, inhibit osteoclastogenesis by preventing the interaction of the receptor activated of nuclear factor kappa B ligand, which is called RANKL, with receptor activated of a nuclear factor kappa B. The cellular reservoir are osteoblasts, bone marrow stromal cells, and follicular dendritic cells. RANK is a heterotrimer cytokines is the cellular reservoir of RANKL formed by osteoblast, bone marrow stromal cells, and chondrocyte, also activated T lymphocytes, TC D4 and TCD positive 8, expressed on osteoclast progenitor cells, mature osteoclast, chondrocyte, dendritic cells, and trophoblast. Studies conducted on RANK gene knockout animal models revealed that in these mice, osteoclastogenesis inhibition, absent of osteoclast associated with several osteopetrosis was observed. RANKL, other name of RANKL is osteoprotegerine ligand, osteoclast differentiation factor, a tumor necrosis factor related activation induced cytokines, is identified to belong to the tumor necrosis factor family and has been recognized to be the only cytokine to play an essential role in bone metabolism as it regulates the development, maintenance, and activation of osteoclasts, thus play a vital role in osteoclastogenesis expressed on the plasma membrane of stromal and osteoblastic cells. A study conducting on RANKL gene knockout animal models revealed that in these mice do not display osteoclastogenesis. The interaction between RANK and RANKL signal the initiation of both osteoclastogenesis and activation of osteoclast. At the same time, RANKL is a ligand for the soluble receptor OPG, and this interaction blocks osteoclastogenesis via RANKL. Thus, RANKL has a double antagonist type action on osteoclastogenesis. This slide shows the interaction between RANK and RANKL. When the RANK is fused to the RANKL, the activation of osteoclast occurs and bone resorption formation. But when the OPG fuse with RANKL, the activation of the osteoclast is stopped and no bone resorption occurs. Systemic regulation of bone remodeling depends on many factors. One of them is parathyroid hormone, which is synthesized and secreted by parathyroid gland. Function of parathyroid hormone maintain blood calcium homeostasis, and this stimulates bone resorption through the synthesis of RANKL on the part of the osteoblast cells, also induce the synthesis of IGF-I to stimulate osteoblast proliferation and differentiation. Another systemic factor is calcitonin. It is secreted by the thyroid C cells. It mediates its action through the calcitonin receptor. It increases bone formation by inhibiting the release of S1P from the osteoclast, also increase the extracellular level of insulin-like growth factor 1 and 2. Another factor is vitamin D3 is essential for normal development and maintenance of skeleton. Active vitamin D3 play a central role in calcium and bone homeostasis through binding to the vitamin D3 receptor, present mainly in intestine, bone, kidney, and parathyroid gland. Another factor is insulin. Target osteoblast directly and stimulate bone matrix formation and mineralization, and indirectly affect bone formation through stimulation of IGF-I produced in the liver. Another factor is estrogen, is one of the major hormonal regulator of bone metabolism in both women and men. Estrogen attenuate osteoclastogenesis and stimulate osteoclast apoptosis. In osteoclast, estrogen block, RANKL, macrophage stimulating factor induce activator protein 1 dependent transcription. In addition, estrogen has also been shown to modulate the production of a number of bone-resorbing cytokines like 1, 6, and tumor necrosis factor and others. Androgen is a well-known and intensely studied hormonal regulator of postmenopausal bone health in women. It can indirectly inhibit osteoclast activity and bone resorption via effect on osteoblast, osteocyte, and the RANK OPG system. Local regulation. Runx act as a master regulator, a switch that mediates the temporal activation and or repression of cell growth and phenotypic gene as osteoblasts progress through the stages of differentiation. Bone matrix proteins such as bone protein, osteopontin, osteocalcin, and collagen type 1, and it seems to control the maturation of the osteoblast and their transition into osteocyte. Osteorex may play an important role in directing precursor cells away from the chondrocyte lesion and toward the osteoblast lesion. Both genes are critical for bone formation. Mice that do not express RUNX2 or Osteorex show a complete absence of intramembranous and endochondral ossification. Bone morphogenic proteins, the action of transforming growth factor beta is to recruit and stimulate osteoprogenitor cells to proliferate, providing a pool of early osteoblasts. In contrast, during late stage of osteoblast differentiation, TGF-beta block differentiation and mineralization inhibition, a proliferation and differentiation of committed precursor into mature osteoclast. Macrophage colony stimulating factor is a secreted molecule that promotes the proliferation, survival, and differentiation of mononuclear phagocytic cells and the cytoskeleton reorganization cells, spreading and migration of mature osteoclast. Is produced by osteoblast and osteoblast precursors, but large amount of M-CSF are also produced by osteocyte. Insulin, like growth factor 1 and 2, the primary function of IGF-I in the bone matrix is to maintain bone mass and skeletal homeostasis during bone remodeling. Furthermore, IGF-I promotes osteoclast differentiation. TGF-beta, transforming growth factor, is to recruit and stimulate osteoprogenitor cells to proliferate, providing a pool of early osteoblasts. In contrast, during late stage of osteoblast differentiation, TGF-beta block differentiation and mineralization, inhibit proliferation and differentiation of committed precursor into mature osteoclast. Interleukin 6 is an anti-inflammatory produced by stromal or osteoblast cells in response to parathyroid hormone and vitamin D3 and on stimulation by interleukin 1, TGF-beta, and interleukin 6 alone or in concert with other agents stimulates osteoclastogenesis. Interleukin 1 does not have direct action on the osteoclast, but like parathyroid hormone act via the osteoblast, it has a direct promotional effect on osteoclast formation. It inhibits the apoptosis of osteoclast. Another local factor is fibroblast growth factor, which is expressed by osteoblastic cells and is an important modulator of cartilage and bone growth and differentiation. The last local factor is osteoclast inhibitory lectin, has been recognized as an inhibitor of osteoclast formation and its related protein member, which is expressed by osteoblast. Thank you for listening, and goodbye.